Thank you, Laura. I will share my screen with you. Yeah, it's working, isn't it? I will try to do my best. Yes, it is. Hello, everyone. Welcome to our first international webinar, or I have to say our first European webinar. INSA Holland and INSA Ireland decided to organize this webinar about nurse-led innovative care. And we are trying to tell you something beautiful. Oh, sorry for my English. I'm a little bit nervous, and I know in 5 minutes it's gone. So don't take in account my bubbling words. The housekeeping announcements are, please take pen and pencil with you because we are going to tell you a lot of information and you can write it down. We are going to record this session and you can always look it back. And there is at the end a goodie bag with all the PowerPoints in it. So we will share a lot of information with you. My name is Loth. I'm a nurse practitioner. I've got my own nursing practice, outpatient practice for double diagnosis patients in the eastern parts of Holland. And I'm the lecturer in the nurse practitioner course, the head lecture, as we say in Holland, for addiction and addiction treatment. And I will tell something later on about the addiction course I'm leading. I'm working with a GB for in the eastern parts, and I'm INSA Holland board member. So I will tell you something about the program now. We are starting now with my introduction. After that, our colleague Catherine Comiskey is telling us something about the healthy addiction treatment model, and she will introduce herself. After her lecture, my dear colleague Teie Salomons from the Netherlands is going to tell us something how you implement such innovative strategies and how it leads to good patient outcome care, because he is working in an addiction treatment center that is nurse-led, so it is really possible. And I think he likes his work very much. He will introduce himself too. After that, we have a short break, and then we go out in little schooling rooms to learn our lessons and make an action plan. And then we have a short question and answer session. And after that, we are closing our first webinar. But what is nurse-led care, actually? What is it, or what is it not? It's, if you read the literature, it's the optimal position of nurses in the care process. It's care close to patients, is what we call in Holland, and I don't know if it's a good translation, but we call it over the walls of institutions care, if it's necessary for the patient. And I've got a beautiful case, let's call him Bill. Bill is a 20-year-old boy, young man, I have to say, and he is suffering from autism and ADD, and he is heavily addicted to speed, coke, and a lot of designer drugs. And besides that, he is suffering from diabetic diseases, and he has a very bad self-care in that because he is in a very big denial of the fact that he has to change his lifestyle. So he is very much acquainted with hypos and nearly death experiences, and he knows the ICU unit not as a professional but as a patient very well. And I phoned to the nurse practitioner diabetic care in the hospital in the eastern parts of Holland, and I told her that my colleague coaches didn't know how to give the best help for this young man. And we decided to do what we call a moral deliberation session and a research group around Bill. And in 2 weeks, we will try to organize it. And in the middle part is Bill, and we are going to ask him how we can help him with his problem. And the main part of the addiction treatment will be in my hands, and the diabetic care will in the hands of my colleagues, but we are going to treat him over the walls of the institutions because we need each other for that. Over the walls of institutions, example, but it's also care that focuses on well-being and not only on the illness. So in Holland, we had a long story of the extended arm of the doctor. So nurses were not their own bosses. They had to do what the doctor told them to do. And that is changing in nurse-led care. But what is the extended arm of the doctor? That is not having the full responsibility of your care. It's being dependent on someone else's position and decision. And the most important thing is that our nursing care is reimbursed on the basis of medical care. So our nursing care remains quite invisible. So it's very hard to what's the English word? To prove that our care leads to something nice, because it's medical care and the specific nursing interventions are invisible. And if you want to do that if you want to lead your nursing care into nurse-led care, then you have to be aware of the fact that it's always multidisciplinary and that it's holistic. And that the role of the nurse is changing, and that you are the lawyer or the spokesperson or you're in the advocacy role for the patients. And that's a very big responsibility. And the care is evaluated based on nursing outcome. And the care plans are based on nursing diagnosis. And the nursing diagnosis and the nursing interventions are aimed at empowering the ability to change someone's life. And I'm the lecturer of an addiction module in the 3rd year of the nurse practitioner's mental health care. And they just ended the module and they had to do 2 exams. In the middle part of the module, they have to give a presentation about a proper nursing assessment with a real patient in real practice. And at the end of the module, then 10 weeks later, they have to present in 15 minutes their nursing care plan based on nursing diagnosis. And I listened 3 hours to 15 students presenting their lovely nursing double diagnosis care cases. And I only can show you the labels because my time is very ended in this introduction. So I will show you some beautiful nursing diagnostic labels. And the first one is ineffective coping. And between brackets is the Dutch word, the ineffective coping. Ineffective coping is an overall nursing diagnosis, I think, because all our patients have to deal with ineffective coping. But chronic confusion is a lovely label for a nursing diagnosis too. Or chronic low self-esteem, or decreased diversional activity, or readiness for enhanced power. That's a very beautiful nursing diagnosis. Impaired comfort, impaired parenting. It's a big problem with addicted patients, being a good parent. Ineffective denial, always say yes if you mean no, for instance. Risk-prone health behavior. Impaired I always struggle about the word resilience. Powerlessness. Most of my patients, I spoke this morning, 8 beautiful case study patients in my clinic, and most of them suffer from powerlessness. They don't believe in any future anymore, and they don't know how to do it. And the disturbed thought process is a very beautiful label. So we have to learn to speak in the nursing language by nursing diagnosis. That's nurse-led care. So this is a short introduction towards nurse-led care. And now the floor, Catherine, is yours. And I will stop sharing my screen with you and put my mic on silence and we all listen to Catherine. Please, Catherine, the floor is yours.
Thank you. Thank you so much, Chris. And first of all, thank you to Dr. Chris Loth for inviting me, a veteran in this area, and the wonderful new Dr. Christine Nicky Annunziata from Dublin, who is a new doctor in addiction nursing. And we're very proud of all of you both. So thank you so much for the opportunity to share my work. So I'm actually going to be building on what you spoke about, Chris. Just get my screen share here. And as I was speaking to you, you know, I was thinking about my own work, which we're always learning from one another. Now, am I sharing now? There we go. Now, is that okay, Laura? Perfect. Thank you. So I am Catherine Comiskey, and I'm a professor at the School of Nursing and Midwifery at Trinity College, Dublin, in Ireland. I'm delighted to be here. School of Nursing and Midwifery is one of the top schools in the world. We have wonderful staff and we work with wonderful people. And I think Chris and Nicky are examples of that. But this is a piece of work that was done very much in collaboration with nurses working in practice. So although I work at the university in the School of Nursing and Midwifery, all of my research is in addiction. And this piece of work was carried out with a group of nurses working across North Dublin. And they wanted to develop their practice. They felt that their practice was very reactive as opposed to proactive. They felt that they were always busy, 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 that their caseload was everybody that came to the centre and the different centres that they worked with. And they wanted to be more proactive, and they also want to be more resourceful, using their personal resources and their expertise to help their patients, their clients. So we set about looking at that, and this is the story, if you like, about that. I suppose what I've learned on this journey are three things. Certainly the importance of tackling stigma, and that goes back to what Chris was talking about, and being an advocate for your clients or your patients. I think what's really important, and you'll see in the examples that I'm going to speak to, about having progressive nursing practice, taking leadership, which builds upon the work of Nicky, the importance of leadership, and the importance of nursing research, evidence, and education. And again, building on what Chris was saying, nurse diagnosis and measurement of outcomes. These are three important things. And to illustrate the importance of these three things, I'm going to tell you two stories. I would like you to think about these two stories, and we'll focus on one in particular. First is the story of John, who was a son of a parent who used drugs. And this is not just a story, it's actually a real person who I met in my research. One part of Ireland, this is his story. He was a very young child when his father passed away. It was suicide. His father had mental problems, drug problems, cocaine and alcohol. His mother was also an alcoholic and also used cocaine. Actually, he told me all of his relatives were heavy drinkers. He came from a deprived area of Dublin, and he started using heroin when he was 13. And he had been using it throughout his life, smoking cannabis, I think, from the age of 11. And when I met him, he had actually sort of sat beside me as he was telling me his story and rolled up his trouser legs to show me where he was shot when he was 17. And that was a turning point in his life. And his brother helped him, and his family helped him to get help. And it is a good story because when he did get the help, he was able to move away from the situation he was in, and he was able to now have his own family and break that cycle of intergenerational substance use. And when I met him, it was a very happy story, and he was expecting his second child. but it was a difficult story, and his story had been, one of stigma and the lack of progressive policies. Patricia is another lady that I met, and again, a real person. This is a real story, and this lady appeared in my research several times over a number of decades. She was born in 1965, so she's in her 60s now, if she's still living. When she was 7, she was sexually abused, and there was nobody to turn to. Now, that child, when she was 7, somebody knew that. That child was going to school. Was there a school nurse? Was there, immunizations? Was there somebody who could have found out about that child? When she was 15, when other girls of her age were doing Irish state examinations, she was injecting drugs. She first injected drugs as a result of that trauma that she experienced. When she was 20, in 1985, in Ireland, she had her first relationship with another woman. And there was no progressive policies at that time. This was a criminal offence. So here she was being criminalised for her sexuality. When she was 24, she discovered that she had HIV and AIDS. And that was in 1989, when we were still in the very early stages where there was no treatment that there is now. And at the age of 45, when she perhaps should have been enjoying her life and should have been a bit more settled, she was peeing into a cup on a regular basis to prove that her urines didn't contain drugs. And I think this is a real story of stigma, lack of progressive policies, and lack of maybe nurse leadership at that time or advocacy on her behalf. I cannot turn that story around, but we can go forward into the future. And perhaps you'd like to take a moment and just think, a little exercise we have for you here before I go through with my nursing model, is maybe have a think about Patricia's story and note the lost opportunities. And perhaps, and again, I'm speaking here as well to the class of new nurses there in London, where have you seen already in nursing practice where opportunities may have been lost, and where if the nurse had the leadership and took control, that there may have been a change in outcome. Laura, will I hand over to you?
Yes, thank you. And it's so impressive, this story about Patricia, and that's why we inserted this exercise. Let's take all 1 minute to think about Patricia's story and note the lost opportunity. So we will actually do this in the chat. So if you would like to go to the chat, you see below in the black bar the chat button. Can you write down the moments when Catherine was talking about Patricia's life? Where did you notice some lost opportunities where nurses could have helped already? Just take 1 minute in silence. I know you are on mute, but type your ideas in the chat, please, for the next minute.
I unfortunately can't see the chat while I'm sharing the screen.
No. Yeah, I already see some input coming in. After this minute, we will review the input. So please keep on writing down your ideas in the chat. So about 20 seconds left. And please type your last sentence, your last idea. Where were you triggered being a nurse or being in school right now for nursing? And Catherine, there are about 10 people who put in their input.
Fabulous.
So let me share it with you so you have an idea of what people think. I have here at the age of 5 at school, there could have been a
Yes.
way. That's when she was 7. The PHN would have been there. In school, there would have been a nurse, age 24.
Yeah. If somebody had asked a question, or if that child was withdrawn in school, or if the teacher had said something, or had asked a parent, this, you know, or had mentioned it when the nurse came into the school.
Yeah,
Yeah.
absolutely. And Nuala is also saying abuse not recognized by anyone. She may have been seen by children's nurse.
Yeah.
And Adrian also after the HIV, DX. And Patty also said nurse-led GP practices at a young age already.
Yeah.
And Sadie also says after the HIV diagnosis and during that follow-up. And there are more people talking about the HIV period. Sitting her exams or not sitting them.
Yes. Why didn't she do her exams? You know, this was what all, by law, she should have been doing those exams. You know, nobody
Yeah.
asked why. And actually, what I'm also thinking is, like, currently, is that woman still providing, you know, weekly urine samples? So we can't change the past, but we can influence the future. So perhaps that's something, if it's a practice that's happening in your organization, to look at why are we doing that? Is it best evidence and so forth? How can we, you know, remove the trauma of providing, you know, regular urine samples? It's not a nice thing to have to do in public or, you know, under guidance.
Yeah, absolutely. Yeah.
Yeah.
Thanks everyone for the input.
Thank you. Fabulous. Just for us to think about, not just about the past, but what can we do now? And remember, it's little things can make a difference. So working with the nurses across North Dublin, we, as I said, they were looking at their practice and they recognized that they needed to look at how can we improve our practice, make it more effective. And we did a measurement of our clients' needs. So we went out and we measured the clients' needs. The nurses themselves did a review of existing nursing models. So there are nursing models, and, you know, those that are in class there in London will have been studying those perhaps recently about different models of care. So they said, well, how can we use these to develop an addiction nursing model? So we have the client needs, we have review of existing nursing models, and then we looked at what did the nurses need. So bringing all of that together, my role as the academic was to work with the nurses in practice, work with the client needs, work with the literature, and I developed what I called the Healthy Addiction Treatment Recovery Nursing Model, HAT nursing model. So when we identify the needs, we did notice that, you know, we had nurses who were working in infectious diseases, we had nurses that were working in prisons, we had nurses working in community services. There were different needs across different services. But one prevailing need across all of the different settings was the need to address sort of anxiety and mental health and psychological supports. And there was also an issue that arose that clients wanted to interact more with their nurses. That this, you know, they could speak to the nurse, they saw the nurse on a weekly basis, they might never see the psychiatrist or very seldom see the GP, but they met their nurse, they knew their nurse, and they wanted to have a better relationship with their nurse. So that was what we found. And then when we looked at the nursing models, if we took what they said and what we needed and put that together, we looked at and we pulled out, this is real academic, we pulled out the pieces that make sense. And what we did, we said, right, we need to address client needs. What are the needs? We have to be adaptable. We have to be nurse-led, like Chris said. We have to be measurable for the nurses, measure the nurse outcomes. We must be cognizant of the person and their environment. In other words, do they have family support? Do they have community support? Are they in a prison environment? So this is what's the environment. And these are all key components that any nurse model must address. And the needs are not just physical, they're mental and psychological and social needs. For example, working with parents, and we only have a certain amount of time, so we must use a brief intervention approach. And we're not going to try and do everything, but we're going to try and address one of the key needs. And that's why we had a single measurable behavioral change outcome, just one outcome, one at a time. If you do one thing at a time, you'd be surprised that you can get there. And then putting the academic aspect around that, we said this looks like what we call a Bronfenbrenner ecological framework is what it's called, where you look at the client, you look at the family, the peers, you look at the nurse, the clinic, the community, and you look at the policy. For example, you can't offer safe injecting if you don't have safe injecting rooms as a national policy. And so policy is important. So this is, if you like, a scheme of the model. So if you take a look at this, you just see on the outer ring are things like, have we the money? Have we written this down? Have we a nursing model manual? Do we have nurses who are going to champion this? Do we have implementations to support the changes? And then if you go inside the circles, you can see, do the staff have training, continuing professional development? Do we have leadership? Do we have access to family if we need to access family, and so forth? All aiming towards the bullseye, the center, improved client outcomes. And this is why it's this sort of model. So that was it in theory. How do you make that happen in practice? It's all very well in the classroom. How do we make that work in practice? To make a model work in practice, you develop what we call a logic, a local logic. You get, well, what do we do? And this is what it looks like when you fill it in. So what are our needs? Our needs are client mental health is our main need. What would be the needs in your practice, in your center, or where you're working at the moment? What are the needs? My nurses' needs was mental health for their clients. What activities are we going to do to address that? And for example, in this case, they said, right, let's work with the 30 clients that have the greatest need and, let them self-select those. Let's offer this extra service. Let's give them 40 minutes, in this case, 45 minutes of an intervention. And let's, work with them on their psychological or mental health needs without going outside our scope of practice. What can we do? If we do that, what would we expect our short-term goals to be? One, in our case here, was to look at triggers, working with triggers. What makes the client anxious? Maybe it's an upcoming court appearance. So we'll work with the client and saying, all right, you've got a court appearance coming up. Who's going to go with you? Who's going to go with you to that court appearance? Have you thought about what you're going to say? Have you got your solicitor? Have you spoken to your solicitor? And preparing them just through a brief intervention for that court appearance. And what might be the longer term goals that we would achieve by bringing in this change in practice? And in this case, it could be improved mental health. It could be new pathways for access to other services and so forth. So this is a logic model that you agree as a group of nurses working together in practice. When this was presented to the team, and remember Chris said at the beginning, it's multidisciplinary. When this was presented to the team in the centre and the group of centres, the psychiatrist and the councillor were initially not happy. They said, oh, are you working outside your scope of practice? But we said, no, this is just a brief intervention from the nurses, addressing not psychiatric needs or counseling needs. It's addressing, what they're looking for from their nurses. So then the counsellor said, oh, I suppose if you do that with the clients, then when you do refer the clients to the counselling, I'll be getting the people that really need it, not the people that you can help in your practice. So it'll reduce my workload. And then the psychiatrist said, if the counsellor does the same thing, then I'll get less referrals and it will reduce the people that I need to see. I'll only be seeing the people that I really need to see, and I'll have more time for them. So there was a level of communication and sharing here that was really important, that explaining that the scope of practice was within the nursing scope of practice and not outside it. But by staying within that and addressing these needs, that it would actually help and contribute to better practice within the counsellors and the psychiatrists. So they implemented the model. And we studied the implementation. We said, well, is this actually going to work? So we did one-to-one interviews with the nurses to see how they were getting on with the model. We actually looked at the outcomes to measure, and we looked at the documents to see, was it actually happening in the documents within the service? And we actually also spoke with the clients. When we did all of that, what we found from the clients was their level of trauma was in fact really high. And most of that trauma came from adverse childhood experiences. And within the adverse childhood experiences, we found that it was feeling unloved as a child was the biggest predictor of trauma. So during the implementation of this model, the nurses in practice said, we need to learn more about trauma. And they brought in trauma-informed training. I took part of the training as well, even though I don't deliver practice. And we did a day's training on trauma-informed practice and modified our practices in terms of trauma and reducing trauma. And that's an example of implementing and action research as you're implementing a change. What we found when we did this, that the nurses felt the model worked well, but there was still some operational challenges, and that's why you do this change as you're going through. Case management worked well, but more recording of the data was needed. And again, this is number 3, data capture was sparse. But if you don't have the data, you don't have the proof that it's working. You must capture the data. Here is a list of all the known aspects that if you want to implement a change in your practice, that the literature tells us these are the things you must look at. So we actually looked at all of these. And what did we find out of all of that? We felt that the nurses were doing really well in terms of the enablers and the drivers and managing change. That was really well done. They looked at these improvement cycles. That was really well done, like found that they needed more training on trauma, addressed it and introduced it. Where things needed to be improved, we called it Code Orange, collecting the data so that you have some data was being collected, but not always. That's really important so that you can measure your intervention. So the next steps in terms of rollout to other locations, if people are interested in rolling out a model like this for their own locations, you need a local needs analysis. Our needs are not necessarily the same as your needs. You need training on how to bring in the model. You maybe do a pilot study on implementation to see how does it work for the nurses and for the clients. And to help with that, we've actually developed an online training, free, I'll repeat that word, free, MOOC, massive open online training course that looks at leadership and nursing practice and this model. It's called a massive open online course, and I actually checked it today, and nearly 5,000 people have actually done that course. Yeah, over 4,800. I checked it this morning. It's only 6 hours. You can do it over a period of 3 weeks, then it's free. And if anybody wants details, you can contact me, or I have them on the slide. There is the details of the course, identifying and responding to drug and alcohol addiction in nursing and midwifery and allied healthcare practice. We're sharing our learning, big into sharing learning. There's a book that I'm involved with. We've published in the Addictions Nursing Journal, and these are where we've actually written up and published about the model. And these are all the people that helped us. So thank you very much. That's our story. Thank you, Laura. I'll stop
Yes.
sharing.
Thank you very much. And I find it so interesting that you started with the research, and then it started, first was the reaction, it's out of our scope, but then it was like, yeah, we can use this and let's see how we can roll it. And the MOOC is, of course, a great success.
Yeah, we're pleased
So,
with that. Yeah, we want to share. You know, we do this because we care.
Yeah.
We want to share the learning.
Really, yeah, really well done. And I'm now asking the audience, maybe you have some thought or questions for Catherine. Now is the moment to ask them. Feel free to unmute yourself and ask that question. So let's see if anyone has a question at this point. There'll also be at the end of the webinar, there will also be time for a question, but please, do you have a question? I see, yes, Adrian raising his hands. Thanks, Adrian.
Catherine, it's a great presentation.
Thank you.
I have a concern. This is one of my primary concerns. Trauma-informed care is the approach I think we've all done in mental health nursing. I've got a concern that, are we skilled enough to unpack, evaluate, and then repack what people are saying? Because often this trauma is very entrenched. I've written down what you said. So 47% of people identified ACEs as one of their factors, and then 35% said it was some form of childhood activity. Are we skilled enough in nursing curricula, or even in addictions training, to repack what's given to us and put it back in a safe way? Because that's my big concern about mental health nursing at the moment, that this is a word that's been buzzed around since it was first written about turn of the century. Are we actually skilled enough to repackage and give back for some actually distressing cases?
Yeah, that's a good question. First of all, I'll just let you know that there is we have published a paper with those numbers, and that show that feeling unloved as a child contributed most to current post-traumatic stress disorder amongst people who use substances. It was the biggest predictor, not physical or sexual abuse, but actually feeling unloved. Well, I'm not a mental health nurse, but Philip is there if I'd say anything he wants to correct me on. The nurses that I was working with were not mental health nurses either. What they did was they looked at their processes rather than, their treatment, if you like. It was more their processes. So in terms of, for example, if somebody does have to give a urine sample, not following them, walking close behind them as they're going down to the bathroom, giving them that overcrowding feeling. So it was more about processes rather than care, if you like. That was how they kept within their scope of practice. I'm not sure if Philip wants to add anything to that.
Can you hear me?
Yes.
Yeah. My frustration as a mental health nurse working in Ireland is just, I do not understand why addictions are not part of the mental health services. Because a huge amount of people have trauma and would benefit from psychiatric treatment or psychological support. And the mental health services are ideal to do that, but they're basically put into services that were originally developed on a very medical model, much more medical than the psych services are, with GPs, and it was focusing on, I suppose, injecting drug use and stuff like that. And so I just don't understand why we don't just move it into the mental health care and treat people with whatever addiction within the mental health services. But that's my frustration.
Thank you.
Yeah. Yes. Adrian? Yeah, good answer.
Yeah, it was a good answer. I'm just checking if there's anyone in the group who've got any questions. No, there's no one in my group.
I think you were saying there, like, I'm general trained, but I think just sometimes when is almost the transformed care, and just being aware there. Um, I think 45% people.
Oh, I'm sorry, Nuala. Your sound doesn't come across very good.
Oh, the kitchen.
Maybe
Let me just.
do you want to put it in the chat?
Yeah,
Yeah, I'll do that. I'll do that.
Yeah. yeah, that would be nice. So we can answer your question. Yeah. And thanks, Nuala. Yeah, it was just a bit wobbly, the sound. So if you can put it in the chat, we can see your input in the chat, and then Catherine can read it and answer if you have a question. And in the meanwhile, I'm gonna talk a little bit about the next steps in our process. Our second keynote speaker is from the Netherlands, and he will talk about how in the Netherlands the nurse-led care is being taken care of. And then we'll have a small break, just 5 minutes, and then we go back to the head recovery model, and we will do a small exercise when it comes to your practice. So that's a little bit when it comes to the next steps. And Nuala, let me see if we can already see your question in the chat. I'm not seeing it yet. Or will you keep it for later, maybe? I'm not sure. We can't hear you right now. You're on mute. Yeah. We'll get back later to your question, Nuala. Let's continue with, here it is. Not so much a question, but I just was thinking that just being trauma aware is really important.
Absolutely, yeah.
Yeah.
As Adrian was saying as well, you know, this is now we're more aware of how important this is. I mean, if you look at the two early stories, the story of John and the story of Patricia, you know, I mean, John would have gone through his life being, you know, the outsider. You know, can you imagine in school, you know, his clothes weren't clean, he wasn't fed, he was trying to feed his younger brothers and sisters, he was probably stigmatized, he was probably, you know, given out to, as we say, you know, criticized in school, probably didn't have the homework done, and all of that trauma is built up over the years. And we just need, you know, across the board, in all disciplines, I think, of nursing, you know, there's a big thing at the moment in terms of schools, to be trauma-informed schools as well, and school nursing and teachers across the board. So yes, Nuala, I completely agree with what you're saying there. So thank you for that.
Yes, thank you. Yeah. And
I think it's that whole thing that, you know, they say that most people who present with addiction have trauma, but not every person with trauma has an addiction. So in any aspect of your nursing, whether it be general nursing, whether it be mental health nursing, public health nursing, school nursing, being trauma aware is very important. You know, you never know.
yeah, true.
You never know what that short intervention could be preventing in the future.
Yeah.
Yeah, thanks. Yeah, absolutely. Yeah.
And the psychologists we were working with on some of this work on the adverse childhood experiences is explaining that you can have the same experience with different people, but they'll have a different, you know, it'll have a different impact, even though it's the same experience. So as exactly what Aisling was saying there, not everybody is going to react in the same way. Some will maybe go on to use substances and others won't.
Yeah, if you look at siblings, for example, in families,
John's family, yes, his older brother, he said, was, you know, didn't use substances.
Yeah, thanks. And for the next speaker, I'm sure you recognize the focus on trauma. Teie, can you please share your slides and tell us your story of your group of colleagues?
I'd be happy to. Let me also see if I can get it working. There we go. You should be able to see it now, right?
Yes.
Fantastic. All right. Good afternoon, everyone. My name is Teie Salomons. For the English-speaking people here, you can just call me Teie or something similar. I'll respond to that. I'm an advanced nursing specialist or a master of advanced nursing practice, specialized in mental health care. I've been that for about 10 years, and I think I've been a nurse for around 20 years now. Currently, I'm working as a director of treatment for the clinical care and the methadone care in the organization I work for, which is Amethyst Addiction Healthcare. I'm also the head of care there, specialized in dual disorder treatments, and that means that I specialize in treating patients who have a substance or addiction problem with a comorbid psychiatric issue or illness. And I've always been very active in the positioning of nurses and nursing. Even when I started out as a nurse, I always wanted to position our field or the work we do in a better way. I'll be talking about how my organization has transitioned to a nurse-led organization over the past few years. And if you have any questions about that, please write them down, and at the end there's room for questions. Now, I'm going to tell you about how my organization developed, what kind of results that gave, what was the impact on nurses, on our patients. But before I do, I have one very important message to start out with, which is kind of the core of my talk in a sense, and that is that I have the best job. And I think this is important because we're suffering from a problem in our healthcare system, and I think it's kind of worldwide. I know at least that in Ireland, similar problems are arising. And that is that we have a shortage of healthcare workers. And this shortage will only increase in the upcoming years. People are leaving the field. Nurses no longer want to work as nurses. And I think it's in part because we're losing control of our work. We don't have enough influence in the field. Working in a nurse-led organization means that you as a nurse really matter. You have an impact on the treatment, an impact on what you do for your patients and how you apply the skills you have to each patient. And that's what really improves working conditions. These are all in Dutch, but these are examples of news articles in the Netherlands about staff leaving the healthcare. And one of the things we see in that is that a lot of people leave our field, not just because of not because of salary problems, but mostly because they don't feel like they're in control of their job. So everything I'm going to talk to you about now, about results, etc. Keep in mind that one of the bases of nurse-led care is just making sure our nurses have a good working environment. But like I said, we have a problem in healthcare, or problems are arising in healthcare. We're getting more patients, the population is getting more and more older, and we have less people to take care of them. We noticed this problem in the Netherlands as well. And the Dutch Healthcare Authority wrote or did a lot of research on it and has come up with a plan to make sure healthcare is sustainable, that we'll be able to keep providing proper healthcare. And the method they want to do this by is by developing what we call fitting care. The Dutch word would be passende zorg. And fitting care is quite an extensive program, but it has a few guiding principles. Fitting care always means care together with our patients and around the patients. It has a big focus on health instead of illness. It means that patients get the right care at the right place, given by the right caregiver, and it's value driven, which means that the values of the patients matter and are what drives the healthcare. For the talk I'll be giving today, I'm going to focus mostly on the second principle, the focus on health instead of illness, because this is kind of new, at least in a healthcare system. For nurses, this should be what we've been doing for loads and loads of years. But for the healthcare systems, you see that a lot of healthcare systems in the world are very driven by illness. We set a medical diagnosis and we provide healthcare based on that illness, instead of care that focuses on improving the health of our patients. Sometimes we confuse the two as well. We think that, if we remove the illness, the patients will be healthier. That's not always the case. For example, take someone who suffers from a psychotic disorder and starts getting high dosages of antipsychotics. They might, not suffer from the illness as much, But these antipsychotics have side effects. They might gain 40 kilos, develop diabetes, not be able to go outside anymore. Then you can still say their general health might have decreased, even though the illness has been treated. Now, there's only one field or one field of healthcare givers that really puts health in the forefront, and that's the nursing field. If you look at what is nursing care, it's care that's focused on promoting health, promoting recovery, growth, to prevent illnesses, and to help people cope with certain treatments of their illnesses, or to at least minimize the impact a certain illness has. And we're in a unique field in this, that we have the healthcare focused outlook, or the improvement of well-being as our core principle. And this is important because the way nurses do this is by adding or working with the base needs of our patients. Some of you might be familiar with Maslow's hierarchy of needs, but what it says is that for every need, you need a certain basis to build up on. So you can only achieve self-esteem if love and belonging, safety and security, and your physiological needs are met. And nurses tend to focus mostly on the bottom two layers of this pyramid, the physiological needs and the safety and securities. And by doing that, they provide a unique and stable basis for our patients to improve upon. This is something I always feel we should be very proud of, that we're the healthcare group that really focuses on layering or laying a basis down on which our patients can recover. Oh, I'm going too quick, sorry. So in the Netherlands currently, we have a system where we want to change toward more health-based focus. We have a group of caregivers, which are the nurses who work through that field, and the way they work, through that view, I'm sorry. And the way they work is by really adding certain base needs to our patients. Now, I'm going to take you to the daily practice, or how can you put this health-focused care into practice. That was one of the challenges my organization had, and I've had it a few years ago. Let me tell you a bit about Amethyst Addiction Healthcare. It's a relatively young and new organization. We came around in 2013, and we provide clinical and outpatient care in the center of the Netherlands. We have a clinic where we provide care to around 35 patients, and we provide a lot of outpatient care all throughout the center of the Netherlands, for around 1,750 patients currently. And we have a little over 100 employees of different backgrounds and specialties doing that. In 2018, my organization developed a new vision on their care. Up until then, it was very illness-focused care. The view was that addiction is an illness. We should focus on curing that illness, and that's the main vision we have for the way our care should be brought. But it changed in 2018, where it was no longer care based on curing the illness. No, it was care based on improving the well-being of our patients. And this is and this is a big change for an organization. Now you can develop a vision like this, and then put it on your website or stick it in a drawer somewhere. Well, what my organization tried to do was really convert this vision to a daily way of working for employees. And one of the things they tried to, or they went to do then, was to attract nurse practitioners. The director at the time was a nurse herself, and she really believed that working based on well-being was something that nurses always did and always do. And she thought, okay, I think nurse practitioners working in a team of nurses would be the perfect group to make this vision a reality. And what she did is hire 3 nurse practitioners. I was one of them at the time, and they were each put in a certain location in our organization. For me, I was put in our clinic, only for the detox unit at the time. A colleague of mine was put in the methadone program, somewhere in the Providence, and another one was working in an outpatient settings. And we each got an assignment, and the assignment was, if you see improvements in the healthcare where you can change the healthcare, so it's no longer focused on illness, but focused on well-being, make them happen. But you should provide all the care you do in a team. And the team consists of nurses, but also of psychiatrists, psychologists, social workers, so a whole different crew of people. And make sure that whatever care you deliver, well-being is always the leading care. And during that time, the organization also added some what I call facilitating factors, which means that we got certain factors to help us achieve the change towards healthcare or care focused on well-being. One of the facilitating factors was the vision my organization had, that we no longer deliver care based on illness. No, we want to transition towards providing care based on well-being. There was trust in the people who worked for that organization, that you would just show up at work, that you would work hard to deliver care for your patients. There was faith in the employees and caregivers that you would work through this vision. I want to improve the healthcare for the patient who is opposite to me. There was a lot of support given from both the management, but also from colleagues amongst each other. The organization itself showed a certain leadership because this was new at the time. Up until then, the healthcare and addiction healthcare was led by psychiatrists and addiction physicians. A nurse-led care model was a new transition. I remember the insurance companies weren't too happy with it at first. They would complain and say, well, this is not how it works. I'm not sure we're going to pay for this. Our organization was very strong in a sense, showed good leadership. They said, no, we believe in our nurses and our nurse practitioners. We really want to try this. And in the end, they succeeded. But it also expected a leadership from our nurses and our nurse practitioners by saying, hey, we're giving you this role, this opportunity to really transition our healthcare, to really work through a vision that's very close to the vision as a nurse. But we also expect you to take it now, to really make this work. And there was a lot of encouragement, which just meant my boss or my colleague saying, oh, I think it's going well, or you're doing well. We see the change you're making, keep it up. And then we're going to take you 2 years to the 2 years further. So we had a couple of nurse practitioners who started working in different fields with this assignment, create healthcare based on well-being. The facilitating factors were added. And then we forward time 2 years. And then we noticed that suddenly we had several nurse-led programs. Now, this is an important thing I want to point out. The goal at first wasn't, okay, let's transition towards nurse-led care. No, the goal was, let's transition to a care system where improving the well-being of our patients, improving health of our patients is the leading vision. And it turned out that through that process, we sort of organically grew towards nurse-led care. We also noticed we got more and more nurses working for us, and we got more nurse practitioners working for us. You know, by word of mouth, people started hearing about the way we worked, that it was an interesting way of working, that you would have a lot of autonomy and a lot of influence on the treatments you were given. What we also noticed is that there was a better coherence between the different disciplines. So before there was a bit of we had the nurses, we had the physicians, we had the psychologists, and they had difficulty working together. They would all work very much within their own field. But this changed after the transition towards nurse-led care, where the different disciplines would start to work more with each other to improve the well-being of the patients. And we noticed that care was based more on health instead of illness. One of the things we noticed, for example, is that in every care plan that our patients have, new diagnostics and new goals were met. Before the nurse-led care was written, we had goals like, oh, patient is not using drugs anymore, patient is remains sober, the trauma has lessened, things like that. And after the transition to nurse-led care, we got more patient goals like patient is feeling more his self-esteem has risen, family relations have improved, daily activities has been developed, patient has developed a sense of self-worth, much more nurse-focused goals. What we also saw is that the teams that were working on the different in the different units of my organizations had changed. People had left several people didn't like working through this vision. They would be very stuck in the way of, no, we want to deliver illness-focused healthcare. And for some nurses, it was quite a challenge because they had to take a lot of leadership and really carry the responsibility of being the one that would provide the treatment to our patient, but also had to, what's the word in English again? Organize the treatment around a patient. And that requires that you as a nurse take up a very, take a very big role in the care you give to a patient. And for some of our nurses, they said, this is too much. This doesn't fit with me, and sadly they left. But what did happen was that all the nurses who came to work for us were all very independent, very strong in leadership skills, and very good at taking charge of the treatment around our patients. So we found out we were delivering nurse-led care, and that was the moment that we started to read up more about nurse-led care. What is it, what we're doing then? And if you look at the definition of nurse-led care, it comes very close to the definition I started with. That is one of the principles of the fitting care. It's really a way of delivering care that's focused on health rather than illness, and has a big emphasis on life management, much more than on diagnosis and intervention. And this is really a new way of working, but very fitting in the current change we're going through in the Dutch healthcare system. Now, this is all fun, but it only matters if it actually has results as well. Like Catherine said, it's important to measure and to look, well, does delivering care through a certain method has an impact? What we started doing is looking at different numbers. We got, one of the things my organization does is the Client Quality Index, which is a questionnaire we walk through with our patients every 3 months, which is very focused on how satisfied are you with the care you're getting. Before the nurse-led care, we scored a 7.6 out of a score of 10 as the max. And in 2020, there was a 7.7. Now, I'm not going to say there was like a huge increase in satisfaction in our care, but I am proud to say that patients scored nurse-led care just as satisfactory as they did illness-focused or the way the care was focused before. What we did find results in were our measurement of addiction for triage and evaluation, the MATE, the MATE scores. These are scores that you take every intake you have with a new patient, but also at regular intervals to see how effective are our treatments. And what we noticed from that is that people started feeling less anxiety, depression, and stress when you compare the situation before nurse-led care and the situation after nurse-led care. And also were suffering less from substance use and craving to substances if you compare the two situations. Side note of this is always, and it's important for me to name, it's very difficult to distill results of treatment from just one change you have in an organization. For example, between 2018 and 2020, a big pandemic started to arise. It could also have an influence on our treatment results. But scores like these do confirm, at least for us, that our treatment has definitely still been very effective when it comes to caring for our patients. We also looked at what's the impact on our employees, or on the employees working for Amethyst Addiction Healthcare. And there we saw that people started to be more satisfied with their work. In 2018, employees of Amethyst scored their work satisfaction 7.2, and in 2021 that had risen to an 8.1. And the interesting part is that we saw an increase in score for all employees, not just the nurses, but also for our doctors, our psychiatrists, our receptionists, our social workers. Pretty much everyone scored their work as more satisfactory. And one of the biggest changes was that almost everyone said, hey, I'm really able to work within my field, within my specialty at the moment. And I feel like I'm working better with my colleagues. It wasn't, there was more cohesion between the teams. And one of the other things we noticed was that we had quite an average or below average sick leave in after we had implemented the nurse-led care. In 2021, it's just hidden behind my camera, and I don't know. Oh yeah, our average sick leave was 5.1%. And if you compare that to the national average sick leave in healthcare in the Netherlands around that time, it was 6.4%, leading us to think this might also help with just providing a healthy work environment for our staff. Now, one of the things I did last week was go around past several of our nurses and ask them, hey, you've worked here for a longer time, you've seen this transition happen, and I will be talking about this with several people from around Europe. If you could give them an advice, like if you want to transition to nurse-led care, if you want to take more leadership, have more impact in the care you deliver, what would you tell them? And several of them, that was the first and the most hurt thing I had, was show guts. Like, be brave, have courage, just stand for your patient. Please don't keep quiet, but step to the forefront and make sure that you show guts, that you do this. Another advice I heard from several was really try to look through the eyes of the patient, which is hard. I know we don't experience what our patient experience, but try to empathize with your patient. If you were in their shoes, what would you want? What kind of care would you want? And I thought that was a beautiful way how nurses work, that we're very good in emphasizing with our patients and really try to look through their eyes. And the third thing I heard from quite a few was look for examples. Every nurse I've spoken to said, oh, I had this one nurse who was, she was my mentor in this or this organization, or she's my colleague now. He or she is amazing. I want to be like her. And those examples really helped nurses to develop their own skills, but also to improve the leadership they took. I'm going very quickly, but I always speak very quickly. Just to summarize, a quick take-home message is what we found is that care led by nurses results in several improvements. One, we saw better results of our treatments, a big increase in worker satisfaction, and in general, just happier and capable nurses for our organization. Well, like I said, if anyone had questions, I'd love to hear them. Please ask them now.
Yes, thank you, Teie.
Stop sharing so we can see each other again. There we go.
Yeah, very inspiring. Also, the round you did among your colleagues, and I remember to show guts and look for the inspiring examples as well. Anyone who has questions for Teie, who has something that he or she finds interesting to ask. Adrian, thank you.
I was clapping, but I haven't got a question. I like your presentation. I think there is a value in nurse-led clinics and nurse practitioner-led. Do you think it's transferable for slightly lower skilled nurses? I don't know what you call them in the Netherlands or in Ireland. So we've got nurse practitioners and associate practitioners. Do you think master's level is what you need, or can it happen at bachelor level?
I think it can happen in each level, but the reach might be a bit different. I think as soon as you're a nurse and you're standing next to your patient, and it doesn't matter if you're a bachelor of nursing, a master of nursing, that's where you start providing nurse-led care. And I think a lot of nurses do this already, at least I hope they do, but what I found is that a lot of settings are already sort of nurse-led, or a lot of nurses already do a nurse-led care. I think for me as a nurse practitioner, but that's because as in the Netherlands, as a nurse practitioner, you can be director of care, which is, like a certain position. The scope might be a bit bigger, but I still ask my nurses, I still act as the nurses in our organization, when you're next to your patient, or when you're the nurse around the patients, to take their responsibility and to show leadership in that aspect. A lot of my work is dictated by the nursing teams. I just have like blocks in my agenda, and they'll fill in patients. Like, okay, Teie, you need to do this and this, or we think they need this and this, which is a perfect example of nurse-led care. Like, okay, that's showing leadership, taking control of the treatment, thinking with your patients, and then setting out the treatment, or providing a road for your patient to walk on.
Yeah, thank you. And we have heard now our two keynote speakers. And what we'll do after the break that is coming up is transfer all the information you've been hearing towards your own experience and towards your own practice. So we prepared an exercise after the break that you can translate the things that have been said to your own practice. So just take a short break for 5 minutes. In Dutch time, it will be 4:20 and in English time, 3:20. Let's come all back together. I'll announce the assignment and we will work in subgroups towards make it even more practical. So see you in 5 minutes. If you have your cameras ready, that would be nice because I will be sharing and I also will put it in the chat a one-pager, and this one-pager is about the head recovery model, because what we like to do now as the next step is to work on an action plan. And I've just put it now in the chat, but I will also share it so for people who have their cell phones ready, you can also take a picture of your screen. And in this picture, you see the blank canvas of the action model, of the head recovery model. And can you take, please, a picture of this page, or maybe you can download it from the chat or make a print screen, because I have prepared some small groups, and Adrian, you and your class will have your own group to talk about if you had to fill in this action plan, which is what we are going to do. What would your answers be to these questions? What are your clients' needs, your staff needs, the activities that you can implement, but also short-term goals and long-term goals? Of course, in real life, you would take lots more than 20 minutes. But for now, we like to do this small exercise and to talk about this in 20 minutes. So you'll meet in your breakout room about 2 or 3 other people. Please introduce yourself. Take about 5 minutes to do so, and then start work on this action plan, on this one page. And when you return, which will be about 4:45 or 4:45 in the British time, we will select one of the 5 groups to talk about how they have filled in the action plan. So we will actually invite one of the 5 teams to fill in their action plan and to talk about their action plan. Is everyone ready? You've all taken a picture, you've all downloaded it from the chat. And if not, then hopefully the 2 or 3 other people in your breakout room has done that, because I will now open the breakout rooms and you'll be invited to go there, and you'll see a stopwatch in the corner where it counts down from 20 to 0, and at 0 you'll return automatically. So have fun, introduce yourselves and talk about the model, and please think about the 2 keynotes that you've heard. So, hello everyone, returning to the main room. So, who had the best group? Yeah, we joined a couple of times your groups to see how the discussion was going. It was really nice to see. Also, Adrian and his classroom talking about the action sheet. And now, and Ilko actually on his bike. So in Holland, we do everything on our bike, doing meetings, drinking coffee. So he was joining on his bike. So I will select a group, but I have a surprise for you. We will select 2 groups. So let's start with the first group, and that will be Chiara. You were in room number 5, I think, together with Philip and Kelly. Let's see.
Sorry, I was muted there.
So let me show the action slides so you can talk a little bit about, we think about 3 minutes for you to share a little bit about the discussion you had.
Yeah. So I was with myself, Kelly and Philip. Myself and Kelly actually work together. We're mental health nurses who work in homeless services with Dublin Simon Community. So we spoke a bit about how our clients' needs are quite complex and generally hard to kind of pinpoint down to one or two of their needs because it's a mix of mental health, addiction, chronic illnesses and wound care. So we focused on wound care for this, which would be a lot of lower limb ulcerations secondary to chronic IV use. So we spoke about the client's needs. And sorry, I actually didn't write these down, which I'm hoping Kelly did, but I'll keep going. So our client's needs were that, you know, they need wound care and that they also need harm reduction advice and materials to kind of prevent further infections and to be linked in with, you know, appropriate TVN avenues and vascular reviews. And then the staff needs, we discussed that myself and Kelly are mental health nurses. So for us to be trained in wound care, both kind of formally through university and informally through one of our colleagues is also training to be a TVN. So we do kind of our own staff training. And then to have the supplies and also to have kind of a wound or a harm reduction approach.
Yeah.
The evidence-based change that we were discussing was the time assessment. So the tissue, infection, inflammation, moisture, and the edges of the wound. It's basically to make sure that we can assess wounds appropriately and treat them effectively. So knowing what the client needs and like treating the whole patient rather than like the wound itself. So like that, like, does the client have, you know, appropriate food? Do they have appropriate accommodation? What can help with wound healing other than solely the bandages that we use? So the short-term goals, Ellie, do you have them written down?
See if we can hear Kelly.
I can jump in. I have them written
thanks.
down. So from the client's perspective, is trying to manage infections, reduce hospital admissions, and in particular reduce sepsis in the short term. And then from staff, it was just the idea of kind of confidence in wound management and assessment.
Yeah.
So that was the kind of short-term goals there.
Thanks.
And for the long-term goals?
Do you want me to keep going, Kira? I have them written down.
Yeah. Thanks.
So from the client perspective, it's really the idea of kind of harm reduction to reduce kind of injecting and risky behaviors, and I suppose trying to provide stability. So obviously some of them are living rough in places which obviously aren't conducive to healing and all that. And in the kind of from the staff perspective, it's the TVN training that there's one of the nurses doing, but all nurses need some level of TVN training, and trying to come up with a link and system with the overall, I suppose, medical establishment to look after these clients who, you know, probably don't fit very neatly into outpatient departments and all that sort of stuff.
Yeah. And I want to check.
Comment?
With Catherine, if you hear this, what is appealing to you?
I think it's fabulous. It's such a practical, you know, focused idea and plan that, you know, address a very much a pressing need, that you have the resources and the capacity and you can get the training. So that's one of your activities. So to me, that's really excellent example. I mean, you are aware that there's a broad base of needs, but you've targeted one that you said, well, actually, this is one we can do something about now, and where we can bring in training. You'll benefit, the client will benefit, and you'll have short-term and longer-term outcomes. And I actually also think it reflects Teie's presentation as well about taking leadership and looking at wellness, you know, how can we make the person well, and the wounds, you know, more comfortable. So I thought that was a really,
Yeah.
yeah, because when you started off, I thought, oh my God, what problem can they solve? And just like that, you had a solution. I'm well impressed. Well done.
Yeah. Great. Yeah. Yeah. And thank you for sharing your team, actually. And for the second group, we wanted to invite Adrian and his group of students. Can you talk a little bit? We think about 3 minutes. Give us a summary on what your discussion was.
Yeah, is it okay if?
Yeah.
Yeah, 1 second, let me switch this off. If I can show you my presentation, it's a little bit easier.
Yeah, of course. Yeah, thank you. Ah, wow. You already filled it in. Wow.
So we took quite a holistic approach on this. We thought if you're to design a service, you need to have skilled staff. And for the service users, you need to have easy accessibility to treatment. Because we said accessibility doesn't mean physical, it can be mental health as well. And I think what is difficult is accessible staffing levels. I think it's a minimum standard we should be expecting, but I think we all know we're short. Short-term goals, if all of this works, patients get the follow-up at the right time. So whether they need it monthly, weekly, every 6 months, they get it at the appropriate time, and their voice is being heard. Ultimately, if it works right, it's a patient design service improvement. They're the ones who find weaknesses, they're the one who finds improvement, and it works better for them. And for the individual, you've got personalised outcomes and aftercare. And we think aftercare is really important. We've been speaking about the recovery agenda that the government put in the UK didn't really work, but aftercare and wraparound care is what we're really looking for. We took education as our key point here. So specialist education, and I think the students really like the case studies. I think if you provide case studies, it makes you think on a more in-depth level. So I think about the young girl you presented at the age of 5, 14, etc. The impact points we could have used. If you provide a good standard of education, you can have safety netting so everyone gets an acceptable level of minimum care, which means there's no additional harm. And if it's done correctly, professional boundaries are acknowledged and understood. With all of this, overall standards should improve because you've actually provided your minimum standard. And if people feel involved in a service, they can actually have self-improvement, team morale will go up, and actually share principles. So you're actually fighting together as a workforce. So that was our presentation.
Wow. Catherine, your reaction?
Well, that's fabulous. Much at a much higher level, at a bigger level. The two things that really stood out for me there actually were the client participation, which I think is really, really important, and the staff sort of satisfaction and training and involvement. And, you know, I'm all for the people first, you know, the people that are providing the service and the people availing of that service. And within your model there, you've actually really highlighted the importance of the client participation and the staff training and the staff, you know, job satisfaction. You know, going back again, reiterating Teie's example, where, you know, when you have this nurse-led care, that it's actually better for staff in terms of their training, their leadership, and the people who are part of that service. So those were the two things actually that stood out to me, that I think that the evidence is, you know, is supported by evidence, that stakeholder and peer engagement and that leadership and staff, looking after your staff, so important.
Yeah.
Thank you for that. Yeah, different, very different. Isn't it interesting how very different models, but both very effective? Yeah, thank you.
Yeah, and I think filling in the model is also a form of leadership, right? Because this would fit Adrian's team and they will feel committed to do so. And Chiara's team has a different approach, but yeah, it's their planning, it's their commitment also. And I just wanted to check, Teie, you've seen both head recovery models filled in now. Did you also recognize the nurse-led focus in here?
Yeah, I think, and it's interesting to see it on so many different levels as well.
Yeah.
It's kind of what Catherine and I were talking about before, but definitely, yeah.
Yeah, absolutely. Yeah, and yeah, I think we wanted to do this exercise because we can talk about nurse-led practice, but yeah, you have to make the next step and start planning it. So that's why we wanted just one time for you to really go through the sheet, and you'll be really invited to use that sheet. I made a print screen, Adrian, of your group's efforts. So we will include this to our presentation. And for the last 2 minutes, I like to give the microphone to for her closing remarks on this 2-hour webinar. Chris, can you share your thoughts on how the webinar was? And oh, let's see if we can hear you.
Yeah,
Yes.
you can hear me. So now I have to share my screen with you. Yeah, there it is. But it's not in a good modus. So I have to switch now to, yeah. Okay, thank you all for participating in this first international European webinar. I heard some lovely things about leadership, questions about what is leadership. It's more than being a manager, that's for sure. I heard a lovely presentation of Tiara, I hope I pronounce your first name in a good manner, about very complex patients and how easy it is to do your work in a proper way and take your nurse leadership and put in some ideas about nursing care. On the sheet, you can see how you can contact us. In INSA Holland is there and INSA Ireland. And we are trying to bring you some more webinars. And if you have some important subjects to discuss in the webinar, please let us know. And we take that into account. And to all the English students in London, at the end of the addiction course in Holland, I always say to my students, if you go into nursing practice tomorrow, please take good care for the addicted patients because they deserve good nursing care. And do it with your head, your hands, and your hand, and your heart, of course, because the 3 H's are very important in nursing care. And webinars can help you with that. Okay, I think I said the most important things, and thank you, Catherine and Teie, for the beautiful lectures you gave us today. And see you all next time.
Thanks, everyone.
Thank you.
Bye-bye.
Bye. Thank you for your time.